All right, thank you everyone for joining in. So I chose a topic on recent updates in management of myeloma-related kidney dysfunction. I'll get started because I have plenty of slides and I'll try to make sure we finish our time, respect everyone's time. I have no conflict of interest or something to disclose. However, I would like to define recent by I'm trying to summarize what's the update in last 1 decade. I may refer to some older publication just to put a context into, but my goal is to summarize the updates in last 1 decade. Before I start, I would like to revise some information on multiple myeloma, because for understanding the renal issues in multiple myeloma, I think we should have good understanding of multiple myeloma. So allow me to elaborate some basics of multiple myeloma. So we'll start with MGUT, monoclonal gammopathy of undetermined significance, which is defined as M protein, which is monoclonal protein less than 3 gram M spike. And if we were to do bone marrow biopsy, they should have less than 10% of plasma cell clone in bone marrow. But they should not have any myeloma defining events. We're going to define which are myeloma defining events in a minute. The rate of MGUS progression to multiple myeloma is calculated around 1% per year. It progresses to smoldering myeloma. Smoldering myeloma is when M protein increases to more than 3 grams per deciliter. And if we were to do bone marrow biopsy, these patients should have plasma cell clone more than 10%. But again, they should not have any myeloma defining events. Rate of progression of smoldering myeloma to multiple myeloma is calculated around 10% per year, and that's why they need to be followed very closely. Now, multiple myeloma definition is when we have bone marrow biopsy showing more than 10% plasma cell clone, monoclonal clone, and have one myeloma defining event. Just one is enough to define multiple myeloma. Which are they? CRAB. So CRAB is the short form given to it. So hypercalcemia with calcium level more than 11, renal insufficiency with creatinine clearance less than 40 ml per minute, or serum creatinine more than 2 milligram per deciliter. They recommend using CKD-EPI, race indifferent equation, but the data is from older equations before MDRD. But they recommend it might help diagnose it more accurately. Anemia with hemoglobin less than 10 and lytic lesion on either bone scan or CT scan, one or more lytic lesions on the bone for disease. The CRAB will define patient to have multiple myeloma if they have more than 10% plasma cell clone. However, in 2014, they updated the criteria and they are added. They added slim CRAB, SLIM. S means 60%, more than 60% plasma cells in bone marrow. LI is light chain ratio, more than 100. And M stands for MRI, showing more than 1 bone lesions. So if we have slim CRAB criteria, in the later 3 criteria, you don't have to have an end organ damage. Because they propose these patients have significantly high mortality, we don't have to have CRAB features if we can even identify one of those. So that was added in 2014. My goal today to discuss out of all the diseases only Cache nephropathy today, which is primarily associated with multiple myeloma. All of the diseases which are described primarily are associated with MGRS, monoclonal gammopathy, but in multiple myeloma, more than 90% of patients will have Cache nephropathy. They can have a combination of disease, but primary disease is Cache nephropathy, which is the goal of our discussion today. So to summarize, what is the pathophysiology of Cache nephropathy? Light chains having a low molecular weight, they can be freely filtered. Kappa light chain having almost 24 kilodalton, lambda light chain almost 48 kilodalton. They can be freely filtered through the Bowman capsule. They reach thick ascending limb of loop of Henle, where they encounter uromodulin or comprised protein. Binding will create a cast, and they will obstruct the distal and collecting tubule. Now, this picture very nicely depicts the cast. When we stain them, we can see they are light chain stain, but they are the obstruction of tubules with the cast, which is shown with asterisks here. Ultimately, they will lead to rupture of the tubule. And the rupture will ultimately result in extravasation of these light chains into the interstitium, leading to giant cell reaction and interstitial inflammation. And the combination will ultimately result in acute kidney injury. I will go through these topics, which are what I'm trying to highlight in the approach, trying to highlight the recent updates in each category. Feel free to ask me questions in between, after each category, or at the end, whichever anyone prefers. So first, we'll go for role of kidney biopsy in patients with involvement of kidney disease. These are all real patients. So let's discuss with first patient, 55-year-old female who is admitted with decompensated cirrhosis of liver and has chronic hypertension, has acute kidney injury. She is admitted in hospital with 4 milligram per deciliter creatinine. SPAP and immunofixation is performed, which shows 3.5 gram of M spike with IgG kappa. Kappa light chain having 95 milligram per deciliter, lambda 1.2 milligram per deciliter with ratio of 79. Hematology is consulted, bone marrow biopsy is performed, shows 20% plasma cell flow. Calcium and hemoglobin are not remarkable as far as this is concerned. And CT myeloma scan is performed, which does not show any bone lesions. Should be considered kidney biopsy in this person. So let's revise our criteria for slim tap, right? In this patient, do we have more than 10% plasma cell clone? We do, it's 20%. So we need one myeloma-defining lesion to diagnose this patient in multiple myeloma. Do they have 60% plasma cell clone? No, it's 20%. Light chain ratio more than 100, it's 79. We are not able to do whole body MRI while patients are admitted in the hospital. So let's assume we don't have it right now. Hypercalcemia, we don't have. Anemia, we don't have. Bone lesions is negative CT myeloma scan. However, the creatinine is more than 2. Our creatinine is 4. Does this define patient as multiple myeloma? Do we even need to do kidney biopsy? It wasn't until 2014 when International Myeloma Work Group clarified that acute kidney injury, only secondary to light chain carcinopathy, qualifies as myeloma-defining event. Any other renal disease does not qualify. So if patient has light chain associated proximal tubulopathy, light chain associated amyloidosis, that does not qualify as myeloma-defining event, only carcinopathy does. So in this situation, if you were to do kidney biopsy and confirm patient has light chain carcinopathy, that will confirm the diagnosis of multiple myeloma. In this situation, an nephrologist is confirming the diagnosis of cancer actually. So this is very specific situation. Now, let's say we didn't have any grade 1 patients already diagnosed with multiple myeloma. So let's just replace the numbers with if patient has light chain level of 125 with ratio 104. That will define the patient as having multiple myeloma already. In this situation, do we need to do kidney biopsy or should we consider kidney biopsy or can it be omitted? In other words, patients already confirmed diagnosis of multiple myeloma and have acute kidney injury. Can kidney biopsy be omitted and can we presume light chain carcinopathy in these patients? So there are 2 approaches proposed by International Myeloma Work Group, and I'll review the evidence behind each. We should look for degree of albuminuria during acute kidney injury when patient presents with dysproteinemia and look at the initial involved free light chain level. How do they help? Now, this is a very nice publication by Dr. Lung's group in CJSHN in 2012. What they did is they collected all the patients' data they have with dysproteinemia and had acute kidney injury, admitted in hospital with biopsy confirmed diagnosis, and have 24-hour urine protein electrophoresis within 7 days of biopsy. And they plotted their urine albumin excretion percentage in all patients. They had 260 patients with 177 patients of amyloidosis, 28 patients with light chain depositing disease, 43 with carcinopathy, and 12 with ATN. They didn't report urine output in any of that. So if we see the distribution of urine albumin excretion, we can see light chain carcinopathy patients have significantly low urine albumin excretion percentage-wise, even less than ATN patients, while patients with light chain depositing disease and amyloidosis have significantly high albumin level. So if we were to calculate their ability to identify, to consider sensitivity, specificity, positive and negative predictive value, when we use urine albumin excretion less than 25% as threshold, the negative predictive value is almost 99%, suggesting that if patients were to have albuminuria, we can almost be certain patient does not have light chain cast nephropathy. Negative predictive value. So if they have less than 25% albuminuria, the positive predictive value is only 75%. I'll talk about that in a minute. But negative predictive value is 99, meaning that if patient has albuminuria, the chances of having any other kidney disease is much higher. Second, about the involved free light chain level to be discussed. They included almost 103 patients with light chain cast nephropathy, which is confirmed by biopsy, and plotted their initial presenting serum free light chain levels and identified what is their presenting serum free light chain levels. And if there's any, we could calculate the probability of developing cast nephropathy when we confirm the biopsy. And they identified that only 2 patients had light chain levels less than 50 milligram per deciliter, meaning that it is very, very rare to develop light chain cast nephropathy when the burden of light chain is so low, below 50 milligram per deciliter. They further discussed that if it is less than 150 milligram per deciliter, still the probability is low, around 5.8%. But the probability of having light chain cast nephropathy is exponentially higher when the level is more than 150 milligram per deciliter when patients are presenting. So that led to propose criteria. In this was published in 2023, recently in Blood Cancer Journal, approach to presume light chain cast nephropathy. So if patients have presenting involved free light chain level less than 150 milligram per deciliter, we should consider kidney biopsy because the chances of having light chain cast nephropathy in these patients is less. If these patients have more than 150 milligram per deciliter light chain, but have albuminuria more than 10%, again, we should consider kidney biopsy because the chances of having light chain deposition disease, amyloidosis is higher. However, if we were to have involved free light chain more than 150 milligram per deciliter and albuminuria is less than 10%, we can omit biopsy and presume these patients have light chain cast nephropathy. This is the proposed algorithm. Now, this was proposed by Dr. Lung and Dr. Rajkumar, which is a group from Mayo Clinic. There's no other investigator in this one, and this is their approach. But if we see International Myeloma Work Group, again published in 2023, they propose to use the threshold of only 50 milligram per deciliter, meaning that if patients have more than 50 milligram per deciliter without albuminuria, you can presume light chain cast nephropathy without considering biopsy. So you may see sometimes oncologists will say, why do you need to biopsy? It's very obvious this patient has cast nephropathy because that threshold is different. Original data is the same. It's just a different interpretation of the same original data because we discussed it was 6% is less than 150 milligram per deciliter and 2% less than 50 milligram per deciliter.
What is 10%?
10% of total albumin in 24-hour urine electrophoresis. They are not using ratio because the original data is obtained from 24-hour urine electrophoresis. When they plot total amount of protein, M spike protein, albumin protein should be less than 10%.
So then you have to do 24-hour.
That's what the data is proposed, like originally derived from, because ratio is not reliable when we want to make the data. Now, International Myeloma Work Group did recommend that you can use microalbumin creatinine ratio with threshold less than 30, should be considered less equivalent to less than 10%. That's a suggestion, but original data is based on 24-hour urine. So, what are the caveats in using this approach? We should remember positive predictive value of having cutoff of less than 25% is only 78%, meaning that there could be other diseases when we don't have albuminuria, could be possible, especially light chain deposition disease and vascularly limited amyloidosis. This disease was described by, again, Mayo Clinic group. They suggested that patients with vascular limited amyloidosis do not have typical proteinuria you would expect to see in amyloidosis patients. So it's very difficult to distinguish these patients from cast nephropathy because either one of them will not have albuminuria and have light chain levels to be can be high. So we can misdiagnose these patients by using this approach. What's the second caveat? We lose the prognostic information because biopsy does provide prognostic information. A very nice approach for prognosis proposed by International Myeloma Group again in 2020, that they suggested we should use cast count in the biopsy. Every millimeter square, we should count the cast, which are stained by light chains, and higher the cast, worse is the prognosis. And if you put it in context of IPTA, which we traditionally use for assessing the prognosis, higher the cast count with the same amount of degree of IPTA has worse prognosis, meaning that it does help with counting the prognosis. So biopsy does provide additional information in addition to IPTA and cast count. What else is the caveat is, if we skip the biopsy, we won't realize if there's more than one lesion present in the kidney, meaning that almost 10% of the myeloma patients can have combination of light chain cast nephropathy along with light chain deposition disease or amyloidosis. Treatment is different. Patients have amyloidosis, require different treatment than just having multiple myeloma. CAR T cell therapy is approved only for myeloma patients. It's not approved for amyloidosis patients. So if they have combination, the treatment approach can vary. It's important to differentiate these patients. And fourth, holistically looking, we diagnose new diseases only by doing kidney biopsy, right? Cryocrystalloglobulin, some patient can have C3GN with multiple myeloma. If we were to always skip the biopsy, we will not have more data about newer diseases. So these are the caveats about the approach which is proposed about skipping kidney biopsy in patients with multiple myeloma. Any questions about biopsy? Otherwise, we can move on to the next topic, which will be myeloma therapy. So I will summarize. This is broadly speaking, anti-myeloma therapy is divided in three groups: doublets, triplets, and quadruplets. Doublet is when we use bortezomib with dexamethasone-based regimen. Triplet is when we use doublet plus either cyclophosphamide or immunomodulator therapy, which is lenalidomide or pomalidomide. Quadruplet is when we use triplet. In addition, we add daratumumab. This is broadly speaking the categories we can use. Now, as I'm talking about updates, I'm going to discuss very briefly about bortezomib-based therapy, renal outcomes, and daratumumab and renal outcomes. So bortezomib is as we know, it's a proteasome inhibitor. By inhibiting proteasome, we ultimately inhibit activation of NF-kappa B and and ultimately results in decreasing release of cytokines, cellular adhesion molecules, primarily affecting plasma cells. Bortezomib is not renally cleared, and it is not nephrotoxic. There can be significant, I think there was a recently significant debate with the bortezomib is associated with nephrotoxicity, but the conclusion is it is not significantly nephrotoxic therapy. All the prospective randomized controlled trials using bortezomib versus placebo, in addition to traditional chemotherapy, the randomized controlled trial rate of AKI was not higher. So bortezomib, there was a recently a retrospective study which tried to propose bortezomib could be nephrotoxic, but it is highly criticized. And in prospective studies, it has not been shown to have acute kidney injury incidence to be increased. Now, there can be very rare interstitial nephritis or allergic reaction, which are rare, but primarily it's not nephrotoxic drug. This was a very nice summary in 2013, where what these investigators did is they collected retrospective data of patients who received different regimens, and they compared the renal outcomes, and then demonstrated patients who received bortezomib-based chemotherapy regimen had much better renal outcomes than any other regimen that did not contain bortezomib. Summarizing that it should be considered a gold standard in patients who have myeloma and have renal impairment. And it is also referred as renal-protective chemotherapy. It has become standard of care in patients who have light chain cast nephropathy, myeloma-associated kidney impairment, and are diagnosed with multiple myeloma. Now, is there any head-to-head comparison of doublet versus triplet and renal outcomes? Cyclophosphamide-based regimen versus just doublet. There was one study recently published actually in 2020. This is a French group. And what they did is they did randomized assignment randomized trial comparing doublet versus triplet regimen of bortezomib-based regimen in patients with multiple myeloma and have acute kidney injury due to biopsy-confirmed Cache nephropathy and excluded all the patients on dialysis. The randomized assignment was either BD or BCD. They included almost 92 patients in this study in each group, and median age was almost 68 years, and median serum creatinine was around 3 to 3.5 milligram per deciliter, was not statistically significantly different. What was their outcome? The survival was not different, but renal outcomes was also not different. At 3 months, 6 months, 12 months, there was no difference in renal outcome whether we use combination of cyclophosphamide with bortezomib and dexamethasone. Plus, they had more adverse reaction and serious adverse events, including death in patients who were given cyclophosphamide regimen in addition to bortezomib dexamethasone. But they did do sub-analysis and showed that patients who have severe acute kidney injury, they tended to have better outcomes. Very hard to do statistical significance because the number is very low. But authors proposed that when we have severe kidney injury, we should still consider triplet regimen, but in patients who are fit and able to tolerate it, versus frail patients and have minor kidney injury, doublet might be just enough. Daratumumab. Daratumumab, as we know, it's a monoclonal antibody against CD38, which is specific for plasma cells. I would like to include this. I was making a presentation and this study just came out January 25, 2024. And my purpose of showing this study is to show that daratumumab is pretty much becoming standard of care in all type of patients with multiple myeloma. Newly diagnosed, relapsed, high risk cytogenetics, low risk cytogenetics. In this one with normal renal function, they demonstrated that the addition of daratumumab in induction or maintenance is associated with better overall survival in patients when they are followed up to more than 4 years. So it's becoming standard of care. However, what's the data about renal outcomes? All the 3 trials which were in the past, which included daratumumab, excluded patients with GFR less than 30. So we don't have any data to suggest, like we did for bortezomib, that is associated with better renal outcomes and whether it should be standard of care to be included in patients with severe AKI with light chain Cache nephropathy. But I would like to highlight this article and try to show what others are suggesting. This was published in 2011 in JASN, and what they did, again, Mayo Clinic group, 39 patients with biopsy-proven Cache nephropathy with severe acute kidney injury with GFR of 9 mL per minute when they are presenting. And they demonstrated that if we achieve light chain reduction by day 21 of 60%, the chance of renal recovery is much higher than if we were to achieve same degree of light chain reduction later on. Meaning that deeper the light chain reduction, better the renal outcomes. Moreover, they showed that the same degree of light chain reduction is achieved by day 12 is associated with better renal outcomes than the same degree of light chain reduction achieved by day 21. Meaning that faster we achieve deeper response to light chain reduction, better the renal outcomes. This is not traditionally looked at in hematological literature. They look at overall survival and myeloma response at 3 months and 6 months. But from the nephrology standpoint, it is important to achieve the reduction faster and deeper response by day 21 or even by day 12. Why am I discussing about this? Because when we add daratumumab to standard regimen, a triplet regimen, this study was done for amyloidosis, because amyloidosis, they will check light chain levels very periodically, frequently, compared to myeloma patients. You can see that when we add daratumumab compared to the triplet regimen, achievement of light chain reduction is deeper and faster compared to a traditional chemotherapy. And this led to suggest by International Myeloma Group that patients with light chain Cache nephropathy, it is a promising tool. And it will likely become backbone of chemotherapy for optimizing renal recovery in patients with light chain Cache nephropathy. That was in 2021. In 2023, again, the Mayo Clinic group, they recommended that we use daratumumab in every patient. Patients have acute kidney injury with light chain Cache nephropathy. We should always add daratumumab in addition to doublet or triplet regimen, which is chosen for the patients. So for them, it's standard of care. It hasn't become standard of care in other centers yet. I had a patient recently, and this was a patient who came to me for second opinion after he was dialysis found. And I'm trying to put this in context. Now, again, we should never use a conclusion based on a single case, but I'm trying to put a context of what Mayo Clinic group suggesting why we should use daratumumab upfront. This patient had light chain level of 650 milligram per deciliter on presentation. We can see in May 2023, and was presumed to have light chain cast nephropathy at that time. Didn't have albuminuria, had high degree of light chain levels, and patient received plaques for 3 days, was immediately started on BCD triplet regimen. We can see initial reduction in light chain level, but it rebounds right away. In 2 months, he achieves no hematological response. Light chain levels are remaining 293 by 2 months. And finally, daratumumab is added after 2 months, and you can see the dramatic response this particular patient received after addition of daratumumab. By that time, this is his creatinine. He never recovered. So I'm not trying to make a conclusion out of one case report, but this is what trying to put a context on that addition of daratumumab up front could be associated with better renal outcomes in these patients. But we need more and more data that are being published in a very fast pace because these tricks are very new.
I have a question.
Yeah.
Are there other hypothesized mechanism other than reduction in the light chain that accounts for improvement in the kidney with DARA?
That was a very good question. Actually. There was a publication by Dr. Lung that how can we treat myeloma cast nephropathy? The title said, how can we treat cast nephropathy without treating myeloma? And what they were proposing, it's only animal-based studies right now that we can find an agent that prevents binding of light chain to Tom Horsfall protein. And that will prevent formation of cast even with light chain levels being so high. That has been proposed almost 10 years ago. Beyond the animal trial they are trying, they have not had any success yet. So far treatment is myeloma, light chain levels reduction.
But I guess your question was there indirect effect other than reducing light chain, right? Wasn't it?
I'm not sure. That's why I'm asking. It
Very
looks
good
like from the data that I don't know if it's the timing of reducing it that it may work earlier than if you reduce it later.
Yes.
Even if you reduce the light chain burden, it may not work anymore. I don't
Yes.
know.
Yeah, that's what I was trying to suggest in that.
In your patient.
Yes, I was trying to use this data to show it in the patient that if we had achieved the same degree of light chain reduction by day 12 and day 21, the chances of renal recovery is much higher than achieving same after 2 months, which could have been done with daratumumab. Possibly is what the group is suggesting.
So getting back to your first thing about biopsy, not biopsy, in the real world, so if they're going to be treated with everything anyway, all triple agents, I'm not sure that getting a biopsy is worth stopping them from treatment. They should get the treatment. We can see how they respond. We can always biopsy
Yes.
after that treatment and see if they have something else.
Yeah, so in that situation, that's true. If they have myeloma, they're gonna get treatment for myeloma, that's out of the picture. Only benefit of doing biopsy at that time is one, prognostic information for nephrology standpoint, like if you want to keep tunnel catheter or fistula, transplant evaluation, they're
Right.
separate. And second will be if they have albuminuria, they could have, in addition to myeloma cast nephropathy, they can have amyloidosis, and then you are suggesting them this patient should be approached differently in treatment of myeloma.
Right. Because my standpoint, I always, first, if the oncologist is going to treat, let them treat. I'm not necessarily going to get a biopsy unless they don't respond to treatment and then see what's underlying. Because, nowadays to schedule a biopsy, it takes time. So you may be talking about, well, in our system maybe, but there's delays.
Right.
If they have complications from the biopsy, they're delaying that treatment
Right.
for the myeloma that they're there. So I think the first question is whether the oncologist is going to treat, not treat. If they're going to treat, they should go ahead and treat, and we can decide on the biopsy or not biopsy, because they can always change their therapy if there's some other, if there's amyloid there and et cetera.
Yeah, so I don't think nephrologists would ever suggest to not treat.
But they shouldn't hold up treatment.
Exactly,
is what
no,
I'm saying,
never
to get
should.
the biopsy.
The purpose should never be to hold up the treatment. Purpose is to add on the treatment.
That's right.
Meaning that if we have additional amyloidosis, they'll give additional information while they are being treated. for myeloma.
I have another question, and this is, I'm sorry, going back to other slides. Is the mechanism of action of the bortezomib related to NFKB ultimately related to the quantity or quality of plasma cell depletion or decreased function?
Primarily, it's suggestive right now, as of that we know of, is the quantity of plasma cells
Plasma.
and reduction of light chain levels. Because until we achieve reduction, there'll be more important question in MGRS patients. Because if we can improve the quality of light chain, we can prevent formation of MGRS related diseases irrespective of the quantity. Because MGRS is more of a quality problem, and light chain cast nephropathy is more of a quantity problem. But so far that we know of, it's primarily associated with quantity.
Okay.
All right, coming back to our autologous stem cell transplantation, I'll go very briefly on it. What I would like to clarify here, for patients who are autologous stem cell transplantation, they will always consider patients' functional status, their comorbidities, to see if they are candidate to receive transplantation. From nephrology standpoint, we should always remember that when they are considering autologous stem cell transplantation, the melphalan dose needs to be adjusted, and it should, traditional dose is 200 milligram per meter square, but it always adjusted below 30 ml per minute of GFR. It is adjusted by 140 milligram per meter square, or it can be divided 70 milligram per meter square over 2 days. Our center standard is to consider 140 milligram per meter square, which is being used in that patient I just discussed earlier, who is on dialysis. So that patient is going for bone marrow transplantation and is going to receive 140 milligram per meter square. Mechanical approaches. So let's discuss this topic now, extracorporeal light chain removal. So because light chains have very low molecular weight, only 22 kilodaltons for kappa and only 45 kilodaltons for lambda, it is logically thought that because the size is so small, we should consider removal by extracorporeal means to remove light chains, and that will help us achieve rapid reduction of light chains and improve renal outcomes. This was published in NEJM, again by Mayo Clinic Group, and they showed in 2011 that if we use bortezomib-based regimen, which was new at that time, and plasma exchange aggressively daily in these patients, they are able to achieve renal response of 86%, which is very high, very good renal recovery. They proposed that we should use bortezomib-based therapy and plasma exchange because we are able to achieve such good renal response. Again, this is not randomized control trial. This is just data collection from retrospective data collection they had in their sense of because they use this approach. Now, so they propose, this is again their proposal, that we use Plex daily in patients who have light chain cast nephropathy, either with biopsy confirmed or presumed. We should use Plex daily until light chain is reduced below 150 milligram per deciliter. The number comes from data I discussed earlier, or 60% reduction in light chains is achieved. We should perform daily Plex. That's their approach. Now, we can always discuss that. What about randomized control trial? Because this is not based on randomized control trial. So do we have any data? First study was done in 2005 by Canadian apheresis group. What they did is they used chemotherapy in patients who are either biopsy confirmed or presumed to have light chain cast nephropathy, and assigned them in a randomized manner to receive 5 to 7 plasma exchange procedures for the first 10 days of the study entry. What was their baseline characteristic? If we see, I would just focus on their baseline serum creatinine, 5 milligram per deciliter, almost 13 ml GFR. So severe acute kidney injuries include patients with severe acute kidney injury are included in this study. Almost 97 patients were included. If we see their outcomes, I would focus on renal recovery. And if we see the first line, received plasma exchange, there was no difference in renal outcomes in these patients group, in these patients, whether they received plasma exchange or they didn't receive plasma exchange in addition to chemotherapy. And the authors concluded that we do not see the benefit because the molecular weight of light chains, 85% of the weight of 85% of light chains are distributed in extravascular space. So traditional 2 hour of plasma exchange is unable to remove significant amount of light chains, and that's why we do not see any benefit.
Did it actually trim the kappa lambda after the pentatracer?
No. But there was significant criticism of this study. The criticism is, one, they did not do kidney biopsy. They did not include patients with only biopsy-confirmed Cash nephropathy. So it's possible these patients had either different degree of IFTA in different groups, or they had combination of disease. So we cannot conclude based on this patient's group. Second is control group received more dexamethasone containing regimen compared to the other group. So it could have biased. So how about we use only patients who are biopsy-confirmed Cash nephropathy, and they are receiving novel chemotherapy, bortezomib dexamethasone-based therapy, and would we see any better renal outcomes? That was a proposal at that time. So that took 2017. This was published in JAMA in 2017, Meyer trial, using high cutoff dialyzer. High cutoff dialyzer removes molecular weight up to almost 50 kilodaltons, so it removes both light chains, some degree of albumin. In this study, they used almost 98 patients, randomly assigned them into receiving high flux dialyzers or high cutoff dialyzer. All these patients received novel chemotherapy, which is bortezomib and dexamethasone-based therapy. All these patients were biopsy confirmed, and they received 8 sessions of 5-hour-long high cutoff or high flux dialysis sessions over 10 days. What was their outcome? Primary outcome was defined at 3 months. And at 3 months, the outcomes were not significantly different. They did not achieve any statistical significance at 3 months. However, they did follow these patients for 6 months and 12 months. And at 6 months, they had better renal outcomes. 56% versus 35%, which was statistically significant. But authors did conclude that at 3 months, which is our primary outcome, the renal outcomes are not different. But proponents of PLEX will propose that at 6 months, they do have different renal outcomes. So it's possible it does work. It was followed by in 2019 by ULIGHT trial. ULIGHT trial again tried to do the same thing. Biopsy confirmed Cash nephropathy, almost same number of patients. They were also assigned randomly into receiving high flux dialysis and high cutoff dialysis. They received chemotherapy was bortezomib, doxorubicin, and dexamethasone. We don't use this anymore. So there was criticism that why did you use this kind of chemotherapy, which is not being used traditionally anymore. These patients received much more aggressive high cutoff dialysis compared to Meyer trial. They received 8-hour session daily for 10 days, followed by 8-hour 3 times a week from day 12 to 21. And then afterwards, 6 hours, 3 times a week for all the way till 3 months. So they remained on high cutoff dialysis versus high flux dialysis. Outcomes, not different in renal outcomes. So even using aggressive high cutoff dialysis, renal outcomes were not different, but they had higher risk of pneumonia, 30% versus 6%. So increased risk of infection, even death was 19% versus 37%. So this study was very concerning that are we doing harm by using extracorporeal light chain removal? What was the criticism of both the trials? Meyer trial, they did not use albumin as routine replacement unless their serum albumin goes below 2.5 gram per deciliter. Now, we know that high cutoff dialysis can remove albumin and they can have hypotensive insult if we are not replacing them with albumin. So we are precipitating possibly more AKI in high cutoff group. And that's why we didn't see the benefit. That was one criticism. Second, in these patients, control group had more infections, the high cutoff group had more infections and more hypercalcemia incidents. So it's possible they had more acute kidney injury than the control group. ULIGHT trial, they didn't treat the reversible causes. They just randomly assigned patients without reversing the reversible causes first. And they did not use prophylactic antibiotics. So that's why they had high risk of infection. So if we were to routinely replace albumin, if we were to routinely use antibiotics, it's possible the outcome could have been bad. This is again criticism of Meyer and ULIGHT trial, suggesting extracorporeal light chain removal could still be beneficial, which is primarily criticized by the Mayo group.
To clarify, this is more dialytic, this is not plasma exchange. Right?
That's correct. This is high cutoff dialysis because all the studies sponsored by the company, which is sponsoring the high cutoff dialysis membrane.
And these were patients all dependent on dialysis.
They are dependent analysis, they are randomizing him, yes. They require renal replacement therapy, and you randomize them either receiving different membrane. Randomizing is just membrane.
In the earlier study where the benefits was seen much later in the third and 6 months.
6 months and.
Yeah, 3 and 6, yeah, what is the possible explanation? Because mechanical removal should work earlier, right?
Yeah,
Rather
so-
than later.
That's right. So they suggested that because these patients, it's possible they have more acute kidney injury during high cutoff dialysis, and they had some infection and hypercalcemia episodes were higher in this group. The acute kidney injury just took longer to recover from other causes, not from light chain removal.
But this was supposed to be randomized, right?
Yes, it is
Yeah.
randomized, but they ended up having more infection in one
Yeah.
group.
We do know that people with lower albumin on dialysis have higher mortality. And if you're actively removing albumin
Like
daily during
Uh,
the sessions.
this one was 3 times, this was in
No, I'm
person
talking
in
about
10 days.
this one.
Yeah, but that is a marker, while removing albumin might not necessarily
Exactly.
relate to poor outcome.
But then I'm thinking intravascular volume versus extravascular volume, pulmonary edema potentially, and other issues. Yes, it's not very inflammatory response.
When hemoglobin is that's what with the high level, no?
It will be 50 kilodalton, so immunoglobulin IgG is around 150 kilodalton. Albumin is 60-70 kilodalton, so it's like right at the threshold. IgG will be 150, IgM will be 900, so they'll be hard to remove.
Right, this plex you just use for
Plex,
plasma and.
That's why they don't
mix-
discuss about plex,
Right.
that it will remove IgG.
Much more,
and
you're
other-
gonna have more
more
infectious
immunosuppression.
complication and sepsis. That's what
More
it is.
immunosuppression,
Yeah.
that's correct. So I'm gonna make sure we, forward, I'm gonna summarize the data. This is a conservative approach, and that IV fluid should always be gold for urine output. We can use pamipronate based on International Myeloma Group guideline that even if you have severe KI, it's okay to use one dose of pamipronate based on the data we have. What is going to be steroid-protective chemotherapy? Light chain reduction should be considered faster and rapid. The doublet regimen might be sufficient in mild AKI, but triplet should be preferred in severe AKI. Daratumumab can hasten the response and may improve the renal outcomes. Data yet to come. This all 3 publications came out in 2023 about extracorporeal light chain removal. Let's review them. Mayo Clinic group recommends, we recommend performing daily light chain removal with plex until light chain levels less than 150 milligram per deciliter. Published in Blood Cancer Journal. International Myeloma World Group, again published in 2023, said mechanical approaches in combination with the anti-myeloma therapy might improve dialysis independence. This is a grade C recommendation, and they also summarize that at 3 months, the outcomes are not different. And this was a debate published in Kidney 360, again published in 2023, where the moderators summarized. And if we read their summary, considering the patient's burden, cost, and the risk of hemodialysis, we have a clear indication against using high cutoff dialysis in patients with AKI who do not require kidney replacement therapy. In those who require kidney replacement therapy, question remains whether we should add a more efficient membrane with a limited cost. They did not even discuss about plex here. So these are 3 different opinions published in last 1 year about consideration of cast nephropathy and extracorporeal light chain removal.
Although you might think different that the patients who doesn't need dialysis might benefit more if you start them on high cutoff and get the light chain.
Their concern is because now we are introducing catheter. If we were to cause infection, we'll have to hold chemotherapy. And if we hold chemotherapy, that's going to much more increase the mortality of the patient. So introduction of possible catheter can be associated with worse outcomes.
So always, always about senior.
Yes,
Ones that need, if they don't, you're not even considering, that's the opposite of.
that's what the commentary
Right,
says.
yeah.
Here, yes, the kidney disease
And that
commentary
was
says.
debate actually, was about.
Yes.
No.
All right, we'll try to summarize my last topic of kidney replacement, kidney transplant in patients who had dialysis who are all dependent on dialysis from light chain cast nephropathy and recent update in the literature about it. So if we summarize the therapeutic approach in patients with multiple myeloma, we can see the history. In 60s, we only had steroids, and their 5-year survival was less than 10%. When we introduced alkylator agents and then followed by bone marrow transplantation in 1980s, the patient survival increased to 25%. Later, proteasome inhibitors, immunomodulated therapy is introduced, patient survival improves to 35%. In 2010s, the last 10 years, we have daratumumab, like monoclonal antibodies, improved 5-year survival to 55%. And now, in last few years, CAR T-cell therapy is approved, bispecific antibodies are approved, antibody drug conjugates are approved in last few years. And the expected patient survival is supposed to be more than 55% by 5 years. Point is, because of introduction of such new and modern chemotherapy, the prognosis is improving so much. If we just count them by age, because this is the overall prognosis, if we see them by age, and if we take the patients who are less than 65-year-old, you can see even 10-year survival is almost 50%, meaning that 50% of the patients survive more than 10 years. And that data is counted by 2015, when we didn't even have daratumumab and the newer agents, meaning that the prognosis is improving more and more for myeloma patients. So many centers have considered kidney transplantation in patients who were dialysis dependent from multiple myeloma. And there are series of reports, 5 patients, 7 patients, 2 years follow-up, 4 years follow-up. So it's very difficult to compile all the data. However, there was one publication where they tried to compile all the data. This is published in 2012, 2022, where they summarized in a narrative analysis and review of all these publications. And they were able to identify 36 patients. Their median time to kidney transplantation, from the diagnosis of multiple myeloma was 41 months, varying from 23 to 64 months, meaning that between 2 to 5 years after diagnosis of multiple myeloma, they were transplanted. The median time for relapse of multiple myeloma from after kidney transplantation was almost 1.5 years. So if you were to look at the outcomes of these patients, they were followed for, again, median of 48 months, varying different degree of follow-up in different cases. Multiple myeloma relapsed in almost a third of the patients in this follow-up. 12 patients out of 36 patients had relapse of multiple myeloma. That occurred in almost a third of the patients during the follow-up. That censored graft loss occurred in almost 17%, and de novo malignancy, because they have received chemotherapy in the past, and now we are using immunosuppression for transplant. De novo malignancy was seen in 3 out of 36 patients, almost 8% of patients. These were the outcomes. But how about we can identify a specific group of patients who could benefit more than the others? So if we look at them by their hematological response, this is a summary of looking at them by their hematological response. Patients who had complete response were 16 patients, and only 2 of them had myeloma relapse on the follow-up, versus patient who had VGPR, very good partial response. Out of 7, 3 had myeloma relapse in this data. Again, this is all scattered, different isolated case reports. So very difficult to compare it to it, but this is the data we have so far. Now, it's very important for nephrologists or other classical nephrologists to understand what's the difference between CR and VGPR. So I'll just very briefly summarize this. VGPR is when we have 90% reduction in M protein, but immunofixation remains positive. That's called VGPR. When immunofixation is negative, that's called complete response. And bone marrow biopsy should have less than 5% plasma cells. When even light chain ratio becomes normal, it's considered stringent complete response. And when we perform next generation flow cytometry, which is much more sensitive than regular flow cytometry, 10 times more sensitive, and if we are not able to identify any clonal cells, they are considered MRD negative, minimal residual disease negative patients. We can see if we just look at the hematological response and patient survival, patients with complete response have much more better survival than patients with the VGPR. And this is why we are seeing more relapses in patients with VGPR than patients with complete response. But if we were to look at MRD negative patients, which is minimal residual disease negative patients, even at 4 years, not only their patient survival is not different, but they don't have any relapse of their multiple myeloma when they are followed for more than 4 years, when they are MRD negative. meaning that they have the best immunological outcomes. These are not kidney transplant patients. They are just outcomes of multiple myeloma. We are looking based on their hematological response.
So that survival was death due to myeloma.
That's that's overall survival. In myeloma, they are always
They could have died
overall
due to
survival.
other
Yes.
reasons. That's not cancer specific survival.
No. No, but they are dividing them based on their hematological response.
Because
Then
if they
there is
were
the
on
benefit.
dialysis, they could have mortality due to other. Right?
That's right. That's right. But these are patients who are not kidney transplant. They are just looking at hematological response outcomes.
No, but these
Without
myeloma
doubt,
patients could have been on dialysis.
Yes.
Right? So that mortality could have been determined by other factors, not myeloma per se, although
Yes,
myeloma has high mortality in ESRD.
that's correct. Yes, but in hematological literature, again, I'm not going in detail hematological literature. Patients with complete response is always going to have better outcomes than VGPR patients, which is well established in their field. Again, I'm not going in detail.
I'll ask you another question based on that.
So, so what are the concerns of considering kidney transplant that we should be cautious about? There are two reports published about patients who received kidney transplantation and received anti-myeloma therapy when they have relapsed, because the therapy is not the same when you have kidney transplant existing. The first report showed lenalidomide, which is immunomodulated therapy, typically used in patients with normal kidney function, which we'll see in patients with transplant, that can cause cellular rejection. This patient was 5 years post-transplant, baseline creatinine 0.9, develops multiple myeloma, newly diagnosed, gets started on lenalidomide, and develops rejection, cellular rejection in 2 months. And there are a few more reports similar. So they're suggesting maybe we should, there is concern that if we were to use therapy, which is typically used for multiple myeloma in renal transplant patient, it can cause cellular rejection.
I think specifically what they call immunomodulation,
Yes,
which is that type.
yes, immunomodulator drugs. This report was daratumumab used and causing cellular rejection that was highly criticized. In this, investigators showed that they received daratumumab 2 weeks before transplantation, and patient had living genetic transplant and developed rejection, hyperacute rejection within few days. And authors were trying to suggest that daratumumab caused hyperacute rejection. However, induction was used only 500 milligrams of solumetrol. So that was highly criticized that they should not be used to criticize daratumumab, which is such a good drug for myeloma patients, and we should not avoid it. So what is the summary? Immunosuppression, when used in patients with multiple myeloma, that can increase the chance of multiple myeloma relapse. When we use immunomodulatory drug, that can increase the chance of cellular rejection. When we use immunomodulatory drugs, along with other immunosuppression for kidney transplantation, it will increase the risk of cytopenia and other opportunistic infection. And by combining immunosuppression for the patients who have already received chemotherapy in the past, we increase the risk of de novo malignancy. These are the concerns of considering kidney transplantation in patients with myeloma, with history of myeloma. But we should always remember, when we screen the patients, their prognosis continues to improve when we screen them and prefer patients with low risk cytogenetics, younger patients, MRD negativity. Their prognosis is going to be much better if we were to be very selective in choosing the patient. And even in last 5 years, these are all the FDA-approved therapies for multiple myeloma, meaning the prognosis after 5 years is even going to be different landscape in patients with multiple myeloma because of the introduction of newer and newer therapy. So we should have open eyes about considering transplantation. So what does myeloma work group say about kidney transplantation? Again, recently published, and they suggest we do not have enough data to suggest best time for transplantation. We do not have enough data to suggest ideal induction or immunosuppression regimen for kidney transplantation, but they recommend patients with MRD negativity at 2 years might be a suitable time for kidney transplantation, and it is just a panel recommendation and is not supported by strong data. And they recommend every center should consider MRD negativity testing because it is the best predictor for prolonged progression-free survival and overall survival. Our center doesn't typically perform MRD testing, but it can be done as a send-out test to Arab laboratory. And some centers, of course, can do consider based on case-to-case basis, even complete response, stringent complete response, or even VGPR patients are considered for transplantation, but that's based on the risk and benefit discussion between transplant nephrologist and patient.